So I'm John Morley. I'm from St. Louis University. I'm a geriatrician, and my great joy watching all of you arrive. None of you, or most of you, just as a blank screen, a few very nice pictures, was watching one physician arrive or student and have his mask on when he arrived and then take it off when he sat down. So he's making most probably the major point I'm going to make in this lecture, that you really have to wear masks, and that is the one and only really good treatment or preventive measure we have available for the coronavirus. I then had the pleasure of watching the that NRMC duo arrive, and one of them, the male one, gave us a polite COVID cough as he arrived, so reminding us that cough is an important part of the COVID. But remember that we live in Missouri, and if you live in Missouri, this is the center of allergies for the United States, and therefore I'm assuming that he didn't have COVID, but just an allergy. And even if he had a fever, it would not have worried me very much because, quite honestly, at last 60% of people with COVID don't get high fever. And so we're stuck with the CDC guidelines that are not very useful, but tell us that we should do things that are not going to be very helpful. And then the highlight was to see one of the students arrive with a young baby that he was holding, most beautiful baby I've seen in a long time. But the piece of to remember there, because I'm talking on COVID in older people, but we should remember that an inflammatory angiitis does occur in a small subset of young children who get this. So this is a disease that, as we know, covers the whole age group. So now, with a bit of luck, I'm going to succeed in sharing my screen. And the host needs to let me share my screen. At the moment, you've disabled me, whoever's the host.
Let me.
It's always a problem. You've got to find a way to share. So while we're waiting for that, hopefully you can see me here. And I brought along a couple of friends when I came here because I thought I should have some visitors wearing masks. And the first of them is, of course, the pangolin. The pangolin wants me to tell you that it's unfair that he gets blamed for everything because it really wasn't his fault. And it was much more likely the bat's fault. Now I've got to get the bat to come up. Fortunately, you can see both of them are wearing masks. So whichever fault it was is unimportant because realistically, they have their masks on, so they are protecting you from this little guy, who hopefully you can see, which is our COVID that I brought along. These are my favorite toys. I have one more I'll show you later in the talk, but we have to recognize that COVID has taken over the world. These are easy toys to get if you are interested in having toys. They normally sit on my desk at work. Now let's see if I can actually share the screen at this stage.
Made you a co-host, so you should be able to.
Now I can, yes. Thank you. So hopefully at this stage you can now see my screen, and it's sort of enlarged and easy to see. So you can see the little toys in the middle telling us that the problem with corona obviously began in Wuhan, in Hubei province in China, and traveled from there in two directions. The first direction it traveled was actually most probably to the United States, and originally this was in Northern California. A few people got a little bit of a disease there, and it didn't seem to make much difference to them. And then another subset who were at a nursing home up in Washington State got a fairly large outbreak, but it was not a tremendously bad disease at that moment in time. Then the other is that a group of people obviously went from China to Italy, and they took with them a different strain of the virus. This was the C strain, and this is a much more effective strain at causing chaos. And the people from Milan in northern Italy then came to New York, and they started the pandemic that we had in New York, as opposed to the West Coast pandemic. So we have to recognize that there are different types of strains of coronavirus. The problem with viruses is they mutate quickly. We see this with the influenza virus, where every year we get a new strain of influenza. The vaccine manufacturers try very hard to come up with a vaccine that will protect us. And some years it protects a large number of percentage of the people, and other years it's not very good at protecting us at all. We also have to recognize that recently in Thailand, they've come up with another strain of the coronavirus, which seems to be much more lethal than the other ones that have existed up till now. So obviously we're going to have to deal with mutations as this goes forward. So when we look at the pandemic, we've got to recognize that there are people, as is often the case in any viral pandemic, who do worse. And the first is if you have comorbidity, and anybody who has multiple diseases is more likely to have a bad outcome than those who don't. And then the second is older people who often have comorbidity, but also have a decline in their immune system, tend to have worse outcomes than younger people. In the older people, it's possible that people who are frail, and frail people often have an increase in comorbidity, have been shown, at least in one study, to have greater death rates than people who fundamentally are not frail. So the fitter older people tend to do better. High blood pressure, diabetes seem to be particularly prone to getting COVID, as are smokers, or at least have a bad outcome. And then there's the ethnic question, where African Americans or blacks are listed as having a poor outcome. A recent study actually looked very carefully at this, and you're seeing this on the left-hand side of the screen. And what you can see there on the left-hand side of the screen is that basically when you correct for comorbidity and you correct for social status, there's almost no difference in the outcome between the different ethnic groups. I think it's important to realize, because often we assume things without recognizing that the socioeconomic conditions are often a very important part of what causes problems in our patients. And we need to be very careful to look for those things to see whether or not that's the case. So I thought I'd start off in any good medical fashion by giving you a couple of cases. And both of these cases come from Europe. They're both geriatricians and they're both friends of mine. So Matteo Cesari, he's nearly 50, and he worked in Milan at the major hospital in Milan, and he's chief of geriatrics there. And basically, I asked him, I knew he'd had a COVID, so I asked him to describe his case, and he describes what is a relatively mild case in a middle-aged male. He said, I experienced a relatively mild form of COVID-19, no need for hospitalization, but finished up spending 2 months of quarantine at home. He had a few thoughts and feelings. His biggest one was the fear of both potentially infecting or having infected his kids and his wife. He felt that was the worst part of having the disease. The second worst part was being closed in his room, isolated from the rest of the family. The silence outside in the streets, except for the frequent sound of ambulances, was a fear he had to deal with, and he had feelings of sadness and weakness in front of the magnitude of what was happening both to him but the people around him. It was extremely confusing from his point of view how to deal with the unknown disease. Remember, this was early disease in Milano. He had every day he read a new article which gave him another miraculous effect of a certain drug, and then he had to decide, am I going to take this drug, or should I wait for some real evidence? And unlike the politicians, he waited, so he took nothing. And the evidence-based issue for Matteo was one of the biggest pieces of COVID. And then early evening, he was indeed physically and mentally exhausted every day while he had the COVID virus. So the second case I'm going to share with you is Alfonso Jose Cruz Gentov. He is from Madrid, and he's also a geriatrician. And he had a worst case. So let me try and go through some pieces of this. It started on a Sunday in the mountains, more precisely near the summit of Cerro de Almenara, next to the Robledo de Chavela. Clearly my Spanish is horrible, where I noticed the first chill that I attributed to an imbalance between the amount of warm clothing and the coldness of the wind. Nothing else. I felt strong and capable. I returned home after more than 15 kilometers of hiking in perfect physical shape. A couple of days later, he found himself extremely tired with a constant dry cough. He had a growing fever. Everything tasted bad. It was either sweet or salty, and he had no perception of any nuance in his flavors. He then became very short of breath, and while pronation, as he pointed out, has been a major way to treat people, it did not help him very much. For 2 months, he still remembers the first night he tried to prone himself and how he actually got worse. This says that, as always in medicine, we have to individualize the treatment. What works for one person doesn't work for other people. He was unable to inspire deeply with a burning sensation, difficult to describe, and desynchronization of muscles with spasms of the diaphragm. Now, the interesting thing about him is he continued to work while he was having COVID symptoms for at least 2 weeks. And eventually an occupational therapist said to him, please get out of here. I don't want to get sick, and you are putting us all at risk. And this is what he says, and it's true, I think, for many doctors. Many doctors sin of presentism, defined as going to work with diseases with which we would prohibit our patients from doing any activity, as a consequence of a responsibility perhaps misunderstood associated with chronic shortage of public health personnel. And as some of the students go on, you will find that there are times when you feel you've got to go because everybody needs help. This is a really stupid thing to do. So if you learn nothing else from this lecture, learn that when you're sick, going and carrying your sickness to other people, particularly if it turns out to be something like COVID, makes no sense at all. Then, as he got sicker, 2 ICU doctors came to see me. They said it was a courtesy call, as he was a medical partner, and he needed to consider the fact that he may need mechanical ventilation, sleeping without knowing if he would wake up. It's not nice to think about it. And as he pointed out, it did not improve his mental fragility in those times. It was impossible for him to sleep for almost 2 months. And he remembers the first night he did it again. After a week, the oxygen saturation began to drop. I was unable to inspire deeply, and he had these burning sensations. Slowly, he started to get better. This was about 5 weeks after the start of his COVID. He was never ventilated as such. And he said he slowly started the rehabilitation program. I stopped using the oxygen concentrator and started doing breathing exercises and walking for the first 5 minutes around the room. I remained exhausted, but it was going to be better. Every day, a little more, until I got over the walk over an hour at home. At first, I couldn't climb a flight of stairs without stopping. Little by little, I came to do 3 stairs in a row. Yes, drowned and saturated as I did it, improving slower than what I would want, trying to gain weight. After the summer, I hope to go back up to the same mountain. When I get to the top, I will know that I am the same again. And the pictures you're seeing here are towards the end of last year when he and I were both talking in Taiwan. But I particularly wanted to draw your attention to the picture we took in Taiwan at the Disney Square, where basically we were both having a great deal of fun and pointing out that neither of us are always as bright as we think we should be. So this is he, and you can see him enjoying his vodka. Actually, that's Chinese wine drink in Taiwan, with his wife, who forced him to go to hospital in the end after sitting up with him all night when he was refusing to go to hospital, looking at him in disgust as he has the Chinese wine. Apparently, she didn't feel much better about him when he got his disease. So what I hope we've learned from these two cases is there's a large spectrum of COVID. And what neither of them had was a presentation of COVID with no symptoms. And yet about half of people who get COVID present with no symptoms. So let's look at the symptoms that we get and those that are more common in men, in older people than in younger people. So when we look, the classical presentation is cough, sore throat, dyspnea, chills, and hypoxia with a fever. But no fever is not uncommon in younger people, and also fairly common to very common in older people. You can get a whole series of central nervous system effects, of which delirium or encephalopathy, headache, falls, and stroke are fairly common. You can have problems with smelling, tasting, and develop anorexia. You can get a diabetic ketoacidosis because the COVID virus, coronavirus, actually can go and destroy the pancreatic islet cells of Langerhans and produce a type 1 diabetes, particularly in people already with type 2 diabetes. You can get a hepatitis. Myocarditis is fairly common, along with myocardial infarction. Skin lesions are relatively common. You see there the COVID chilblains, which are fairly common. They're most probably secondary to having peripheral vascular disease. And in addition to that, people get deep vein thrombosis. So we've seen that there is an increase in the ability to have hypercoagulation, both with the stroke, the myocardial infarction, and the chilblains. Kidney injuries are not unusual. Myalgias occur, and muscle wasting or cachexia and sarcopenia can both occur within the disease. The muscle wasting and cachexia are particularly common in older people. You can get colitis and a diarrhea, and that covers most of the things, except that, as you all know, you can get a cytokine storm where you get a large increase in cytokines, and the cytokines start to kill you at that stage. Important to recognize many abnormal labs. I would like to just highlight a couple. The one is the increase in D-dimer, which suggests that you may have pulmonary embolism, and you need to be aware that pulmonary embolism is not rare in people with COVID-19. And then the other thing is that people with COVID-19, a subgroup gets syndrome of inappropriate ADH with hyponatremia. So things we should be paying attention to. Remember that COVID, or the coronavirus, enters the tissue through the ACE2, the angiotensin converting enzyme 2 receptor, and that is how it gets in throughout the body. So looking at the classical presentations here, you see there fever, cough, and dyspnea. And if you look basically at the older person, classical presentations seem to be reduced mobility, delirium, and falls. The cachexia is very classical of older people. And here again, it's the weight loss, anorexia, low albumin, and an increase in C-reactive protein. If you look at what we should be doing with people with COVID virus, if they come into the hospital, as Mikel Esquerdo has shown in Spain recently, with or without COVID virus, whatever happens when you're old, you come into hospital, you need to go into an exercise program. And that exercise program should be at least twice a day, most probably done with an exercise physiologist, because physical therapists don't really look at exercise. They look at getting you out of bed, trying to make you function better if you're an OT. But the reality is, if you lie in bed for 3 days, you'll lose about 1 kilogram of muscle weight, and that takes forever to replace that muscle and the muscle strength. So please pay attention to your patients in hospital. No matter what is wrong with them, lying in bed is only for dead people, and getting people up they will have much better outcomes in the longer run, as McAllister showed. This is just going through the inflammatory cytokine effects on muscle, and muscle is one of the sites for the ACE2 receptor, where you have small amounts of inflammatory cytokines, but you're not eating well, so you have a decrease in leucine-enriched essential amino acid intake. You have less physical activity. You might have a age-related loss of spinal motor neuron function with increased motor unit denervation. And basically, many older people have a decline in anabolic hormones. You put it together with the coronavirus inflammatory cytokines, and that can lead to sarcopenia, but it can also lead to cachexia with anorexia, changes in host humoral factors, and an increase in respiratory rate of the tissue. If you basically are thinking the person has sarcopenia, a quick way to make this diagnosis is to ask the SARC-F question, which is, are you strong? Have you the difficulty lifting or carrying 10 pounds, assisting and walking? How much difficulty do you have walking across the room? Rise from a chair? Can you transfer from a chair or a bed? Can you climb a flight of stairs? And then how many falls have you had in the last year? And if your score is 4 or greater, you basically are most probably sarcopenic. You can go ahead and do DEXAs and other things. But quite honestly, the SARC-F questionnaire works about as well as any of the special tests. Cachexia is diagnosed using the Glasgow prognostic score, and it's obviously a combination of weight loss, anorexia, low albumin, and increased CRP, but the prognostic score uses your CRP of less than 10 and an albumin greater than 3.5. If your CRP gets to basically greater than 10 and an albumin less than 3.5, then you're basically looking at having cachexia. Again, if the CRP alone is elevated without the albumin, those are the milder forms of cachexia. But we have to recognize the loss of muscle is extremely important, and this is particularly important following recovery from a COVID episode. The other thing is we have to look at people who come in with COVID, as with anybody who comes into hospital, and say, are they delirious? There are two scoring ways to look at for delirium. These need to be repeated at least once or twice a day for people in hospital. The 4AT comes out of Glasgow and at least Edinburgh, and it's alertness. Can you give them your age, date of birth, etc., etc. Are you paying attention? This is done by getting you to say the months of the word year backwards, and then do you have a fluctuating course or an acute change? And important to realize, a lot of people with delirium just become apathetic and don't function. The CAM is the confusion assessment method. This is Sharon Anaway's method that came out of Yale originally. And it's, do you have an acute onset or fluctuating course? Are you have you inattention? Have you disorganized thinking and an altered level of consciousness? Anything but alert is considered altered. You need to recognize that. Need to point out, and I'll say it more on the next slide, but physical restraints do more harm than protection, most probably in anybody, but certainly in older people. And quite honestly, at this stage, physically restraining someone because you can't look after them in hospital is a form of torture. It's equivalent to waterboarding. It makes people have worse outcomes, and no one should do that. No nurse should take an order from a doctor to do it, and no doctor should give that order. I know this is very difficult in the United States because we are obviously in this form of BDSM for our patients, which I don't understand at all, but it seems to be an American behavior that is unacceptable. In the United Kingdom, if you physically restrain an older person, you will lose your medical license and you will be fired from your job. That makes much more sense to me than what we do here. Please do not use physical restraint. quite honestly, people get worse, not better, when you use them. Now let's go on to people with dementia who get COVID. They get confused, delirious, they have a lot of fear, they feel helpless, they get angry, they can get depression and denial. They don't understand why they're isolated in the social situation. They don't understand why they can't talk to their friends, why their family are not there. They want to know who's going to look after them, and they have huge problems taking their medications, which if you're in hospital is okay. But if you're at home, recognizing that somebody with mild COVID may not take their medications is very important. Want to stress that caregivers are essential to work with demented patients when they develop COVID. And one of the things we most probably did the worst in the COVID pandemic is not having enough PPE available for caregivers to come in and be with their elderly friends, either in the nursing home or in the hospital. And again, just to please remember, physical restraints are a form of torture, and I hope none of you believe that torturing people is a good thing to do. So now let's go on to the diagnosis of COVID-19. I assume that most of you actually know and understand what we do here. We do the PCR, polymerase chain reaction. It's about 97% accurate. It misses the disease in some people in the first 2 days. There's just not enough coronavirus around, and it detects those who are actively infected. Important to do. Unfortunately, for a variety of reasons in this country, we have had major delays in getting it done. For this reason, we went to the antigen test, which we got shown out of the White House. It turned out that the antigen test, which was supposed to be highly predictive at the time it was first shown, turned out to be only about 50% predictive when it got away from the company and we started using it in practice. It's important to recognize that we have to do regular testing of staff, both in hospitals and in nursing homes. A big way in which basically people get infected is staff come in, they're asymptomatic, and they bring this in. I should point out that there is a new approach to making a rapid diagnosis. This is using CRISPR technology. It's very interesting, not yet available, but you can have the answer in about 15 minutes. Antibodies, important to think about. They are good to test if you think the person has had the disease, and you can basically recognize the IgG stays up longer than the IgM, but it only tells you who's had the disease, not whether you're acutely infected at the time. I like showing the robot at the bottom. This is a robot that was developed so doctors didn't have to go in and see the patients who had COVID, and the nurses could also stay outside as much as possible. Of course, we have to recognize that if you're not going in to see somebody, you're not getting out of bed, you're not turning them around, they're going to get pressure ulcers, they're going to get social isolation and depression. So much as I love these little robotic gimmicks, this was most probably not the place to be using it. So what about medicines to treat people who have COVID? So dexamethasone has most probably been shown to have the best effect in hospitalized patients with COVID. And you can see there's an effect there on mortality. It's not huge, and we need to recognize that. Convalescent plasma has an effect on mortality. It seems that if it's given earlier and if there's a higher antibody level, it may work well. But the studies available are actually not good enough to say this is actually true. So we're guessing a little bit. And when we hear the politicians telling us this is a good way to treat people, it's up there with hydroxychloroquine. It's up there with basically thinking of taking some sort of detergent or something intravenously. These are sort of a way to go. Plasma convalescent plasma may be good, but we've got a way to go, should still be in studies. The antivirals, this is the protease inhibitor, lopinavir, ritonavir, remdesivir. an ATP analog, which interferes with the action of viral RNA-dependent RNA polymerase, and tocilizumab, which is an interleukin-6 inhibitor. And for the students out there, what I have to say to you is we're going through a world where we're creating all these great names that are totally unpronounceable, and this just makes it really unfair to try and learn pharmacy and pharmacology for you. Interesting things that are coming down, and by the way, all of these antivirals work a little bit, but not a huge amount. They're about as good as Tamiflu, which has questionable validity in large populations. And then you look at the two things in the future are monoclonal antibodies, which are being developed. And in addition, at SLU, one of the people working with me in the lab is now using an antisense to messenger RNA to see if we can use an antisense to limit the COVID virus. So it works extraordinarily well in cells, but cells are not human beings, and we're at the stage of looking at mice now. So the other thing to realize is when you see somebody in hospital with COVID, we have a maxim that when you're looking at older people, we cure sometimes, we relieve often, and we comfort always. And palliative care is an important part. COVID symptoms are very distressing, including the breathlessness, anxiety, depression, delirium, and agitation. And we have to be able to provide palliation of suffering. Patients with severe COVID can deteriorate rapidly. It's therefore important to have a strategy in place for managing the deterioration. This means we have to have asked people about their advance directives and know what they want. Alleviating loneliness, we've said this before, PPE for family and volunteers, and provision of spiritual care are really important. And clear and timely communication with the patient and their carers is essential. We need to be able to give realistic versions of what the treatments will and won't do. Hopefully we've gone through those, recognizing that when we started out, we used to ventilate almost everybody, but at this stage we realize that many people do better with the self-proning with oxygenation and don't do as well with ventilation. And you're missing the guy on the right-hand side who's covered, at least on my screen, by my face, which is pretty bad. So fundamentally, if you look there, he has got a big plastic covering as a way to oxygenate himself. Since basically the beginning of COVID, this is data from Britain, but it seems to be true everywhere, survival rates have been improved. Some of you may have heard of Dr. Rana Ardwish. She's an ICU doctor in Detroit, and she is famous for writing a book called In Shock, most probably the single best book any medical student or physician should read. And I've read lots of books, and I was blown away by this book. She got a bleed on her liver during a pregnancy. She actually most probably died or almost died once, but she remembered afterwards she could hear the medical students saying, well, she's circling the train, she won't be here tomorrow. And so she likes to point out this is not the sort of thing you say around patients because it doesn't make them feel good. But most importantly, when COVID started, she started to recognize that many people with the increased number of deaths and the things going on with them were getting very burnt out and getting very unhappy. And she has made it her job in her spare time to go around the hospital talking to people who've had deaths from COVID, the physicians and the nurses, and trying to work with them and to alleviate their unhappiness. Very, very important. Really, I think you all should try and read In Shock before you finish your DO school. So the palliative care we've talked a bit about, and remember that really what we're trying to do is maintain grace, helping patients and families to understand and decide, coordinating the care, and making people feel good. Their symptoms we've talked about, but we have to recognize that the medicines include opiates. In this study, they used Haldol. Using Haldol for people who are sick is most probably totally stupid. All the available data says it doesn't work. It's not going to fix the delirium. It's not going to fix anything else, and it may well cause side effects. It has major negative effects on the heart as well. So try and avoid Haldol. If a person is very restless, using very short-acting benzodiazepines may make sense, but on the whole, in palliative care, morphine is going to be your major thing. So we've looked a little bit here at what happens acutely, but as a geriatrician, I deal often with people post the disease. And what we see here is that post-disease, the time to cure is often a long period of time. And it can include anorexia, fatigue, dyspnea, confusion, cough, changes in taste and smell, chest pain from the myocarditis. And remember that the coronavirus does get into the myocardium, and there are postmortem studies showing this, where it has caused local tissue damage within the myocardium. You can also finish up with joint pains, and the road to recovery can be a long period of time. We haven't had people around long enough to realize this. If you don't want to believe that this is a bad thing, Eduardo Rodriguez, who plays for a little-known baseball team called the Boston something Red Sox, I think, who knows, a team I have no time for whatsoever. I'm actually a Dodgers fan, so I live in St. Louis, and I'm not a Cardinals fan. This is really bad. But he got COVID, and he was incapable. He was their best pitcher, and he was incapable of pitching an innings after his COVID, and he's withdrawn from the season to give himself time to recover. He had a severe myocarditis from his COVID. What do we do in rehabilitation? As is said by this patient here, I couldn't stand, I couldn't walk, I couldn't get out of bed by myself. And now I can walk, she said. I am walking with a walker. You need speech, cognition, basic activities, and physical therapy. And this needs to go on a long time, most probably needing an exercise therapist. In the nursing homes, basically, coronavirus has been devastating. As the Spanish army found in a care home, the residents had been dead and abandoned. The problem with coronavirus is, one, we don't pay a lot of money to the people in the nursing homes. Many of them have family members who have got the virus. They get sick themselves. People stop coming to work, and the staffing goes way down. And there is a shortage of personal protective equipment. Recognize that within the nursing home, most people who are positive for COVID, when you have an outbreak, have no symptoms, so you have to test everybody. So testing of staff and patients on a regular basis, which quite honestly, when we had a very good nursing home that had shut down very well, but they got worried about a couple of staff coming in potentially sick, and they asked for equipment to test from the state. The state told them they didn't need it because they were doing a good job. 2 weeks later, they had basically nearly 30% of the nursing home had contracted COVID, and a large number of them died. We need to have PPE for everybody in the nursing home and also for visitors. Nursing homes should never be asked to take untested hospital patients. This was the major problem of Cuomo, the governor in New York, who forced nursing homes to take them. This was stupid and unacceptable. And so if you think you've worked out by now which political side I'm on, the answer is neither. Both sides have done a terrible job. And you've got to be able in nursing homes to isolate people. Important to recognize that distance is really important. Up in the top left-hand corner, way up there, you see that basically a restaurant in China, one person went in with COVID. The ventilation managed to give 11 people, I think it was, COVID after they came out of there, just from the one person who'd come in with it. So we have to social distance. We have to be at least 6 feet apart or 6 foot under. Those are the choices we have. And wearing a mask is absolutely important when you're coming close to people under any circumstance. The face masks required there is with the Billiken from St. Louis University. I had to spend 3 days trying to explain to our people that you can't have doctors walking around without face masks when they come into the doctor areas. They eventually started to put the signs up, and life is much better now. But you recognize that almost everywhere people have tried to show that the important preventive measure is wearing a face mask. You can see here, and I could most probably quickly put it on, but here is a face mask worn by me. You've got to wear a face mask, and the cloth are okay, but not when you're dealing with patients, okay? So here I am walking my dogs with my face mask, but importantly, most older people actually lip read. So if you look at that young lady up there, she's got the ideal sort of mask, a mask that basically allows people to lip read, otherwise they can't understand you. You've all seen, I think, the pictures in the New England Journal and on social media showing that without a mask, the droplets go a long distance, and you basically need to get your mask fixed. Most of the use of the mask is to protect others, not the person who's wearing it. There's a small amount of protection with the cloth mask for people wearing it, but when you go to surgical masks, N50, 95 masks, they give a little more protection to the people wearing them as well. We live in a world, back in 1918, during the influenza pandemic, there was a group of people who did not think they should wear masks, and they were really angry that people made them wear masks. But actually, much of the success of getting the influenza pandemic, the so-called Spanish flu, which, by the way, started in Kansas, in case you thought it was Spanish. So we should never say that a disease belongs to one country. These are diseases that belong to the world, and we need to be important about that. And we see today here people protesting that they don't think they should wear masks, that they are harmful, which is total trash. And we even have a Florida sheriff who banned his deputies, office workers, and people coming to the sheriff's office from wearing masks in the Florida county at a time when the county deaths were sky high. Any politician, any person who's a person of authority and doesn't wear a mask can take the responsibility for the United States at this stage being most probably close to the worst outcome of any country in the world. Only the United Kingdom has tried to do worse, and they have politicians who also have not pushed masks. Lockdown can become very important if you need to do it. Here we're seeing lockdown in Romania. It doesn't matter where it is, but I love the sign there on that box down at the bottom. If you're reading this, you're a COVID idiot, go home. It's important that we isolate people, and for older people, going out as little as possible is important. Social isolation is extremely important. There are loneliness epidemics even before we had COVID, and loneliness leads to stress, depression, poor quality of life, poor sleep, worsening mentations, impaired function, cardiovascular disease, increased hospitalization, increased mortality. The previous Surgeon General of the United States said, as a physician during my years caring for patients, the most common pathology I saw was not heart disease or diabetes, but it was loneliness. And we have to recognize that we have tried, by letting people do window visits and other things in nursing homes, to decrease it. But in our nursing homes, huge amounts of weight loss occurred before COVID got into the nursing home, just from the persons becoming depressed, lonely. And again, mention PPE is needed for all visitors and volunteers in nursing homes and in hospitals. Here we see people finding nice ways to hug people. Again, the window visits, and telehealth is becoming a really important part. And at the end of the COVID epidemic, most probably the best thing that's going to come out of it is high quality telehealth for the whole population. We also have to recognize that ageism is a big problem when we get into things, and COVID-19 has become called the boomer remover, which is sort of very unacceptable. In Italy, where 23% of the population is 65 or older, a number of the hospitals in northern Italy said that if you were 65 or older, you couldn't have a ventilator because basically they didn't have enough. This is called distributive justice. Many healthy younger adults initially ignored recommendations to socially isolate and protect their older patients. This is neglectful, and Governor Dan Patrick in Texas suggested that older people, himself included, would volunteer to die so Americans don't lose our whole country. That would be called stupid benevolency. Please look at realize that older people are valuable. The President of the United States he's my age, so that means he's 74. He's one day younger than I am. The Dalai Lama is in his 80s. Pope Francis is getting up there. And then you look at the Queen of England, who is in her late 90s and often makes far more sense than her politicians. So we know that we should not be ageist, and it's very important not to be. This one I can go through quickly. It just points out that basically things like measles and smallpox and rubella and mumps are much more contagious than SARS. If one person with SARS will get about 3.5 people to basically become infected. The same thing with COVID is similar, and influenza very similar. We need to immunize, and you have to immunize large amounts of the population, because it's only when you get to above 70% of the population immunized that you really create the herd immunity that you need. There are a number of vaccines available. We're very excited in the States about the Moderna vaccine. This is a vaccine that uses an RNA molecule to teach the immune system to target key viral proteins. They're live attenuated. They're most probably not going to be successful with COVID virus. They're the inactive ones coming out of China. They have developed some there, and I heard today that the whole of the Chinese army has now been vaccinated. There are subunits, and then the viral vector, which is a benign viral vector, as such as they're using at the University of Oxford in England. And really, the Moderna and the Oxford ones are the ones we're going to see the fastest. Both the Chinese vaccine and the Russian vaccine, where they're not spending any time at all to see if these are dangerous, are also going to get out there fairly quickly. And this is just showing you here that both of the viruses actually produce reasonable responses as far as what you would like to see when you give a virus. But that does not mean they'll work a long time, and it does not mean that they will actually protect us. We have to be aware that not only do we have people in the States who don't like masks, but we have people who hate vaccines. Somehow the world thinks that if I don't vaccinate my child and they give their disease to 12 people and 6 of them die from the measles, that's okay. I do not understand how you become an anti-vaxxer, and the literature is full of crazy people, including physicians, saying, well, you shouldn't vaccinate because vaccinations are bad for you. No vaccination is that much worse for you than getting some of these diseases and die. About a third of vaccines have said they won't get vaccinated against the virus, and basically recently 50% said they have to know it's safe before they would take it. Americans aged 18 to 24 were the ones who least wanted to get vaccinated, but if they don't get vaccinated, the older people are going to get COVID-19. Men are more likely to say they'll get a shot, and Democrats more likely than Republicans. You can take that for what it's worth. And nearly 50% of participants said they would respect the choice of people who chose not to be inoculated. I don't believe you should respect the choice of people. There are things like wearing a seatbelt, driving at the speed limit, which I'm very bad at doing, that quite honestly, we should respect what the laws say. Remember that what happens with COVID, many people are not around when their loved one dies. This can cause major grief, and if it's associated with social isolation at home, this is really bad, and we need to have programs for bereaved families following COVID. So to finish up fairly quickly, I've got 3 poems I'm going to read you, or bits of, and I should leave at least a minute for questions. I always try not to leave any time for questions because it's hard to answer them. So the first poem is from 1869. It was reprinted in the 1919 Spanish influenza pandemic, and this is timeless. And people stayed at home and read books and listened, and they rested and did exercise and made art and played and learned new ways of being and stopped and listened more deeply. Someone meditated, someone prayed, someone met their shadow, and people began to think differently, and people healed. Let's go on to Donna Ashwood's poem, which is now a recent one. History will remember when the world stopped and flights stayed on the ground and cars parked in the street and trains didn't run. History will remember when the schools were shut and the children stayed indoors and the medical staff walked towards patients. They didn't run. History will remember when people stood on their balconies in isolation, but so very much together in courage and song. History will remember when the people prayed for their old and their weak, protected the vulnerable by doing nothing at all. History will remember when the virus went away and the houses opened, the people came out and hugged and kissed and started again, kinder than before. So now this is my bedtime story for you all and for you to tell your grandchildren in about 50 years' time. Imagine when the world was covered by pollution, not a star could be seen in the sky. White Americans shot young black men for fun. A wall was built to keep immigrants out. The UK Brexited from the EU. Ageism and racism were common. Children starved throughout the world. Middle-aged people in the United States died from obesity. The ruler in Saudi Arabia had a journalist killed and few cared. From Yemen and Africa to beyond, people fought wars. A little man in North Korea threatened to start a nuclear war. Imagine that things could get worse when a small virus with a crown swept around the world, killing large numbers of people. Some called it the boomer remover. Others just said no ventilations for old, or said old folks will die to save the young. People isolated in their houses and became depressed. We masked and didn't come within 2 meters of one another. Well, a few did. Pollution disappeared. Others got guns and protested that they should not need to stay at home to save old people. There was not enough PPE for health providers. There was an economic crisis with those people working. Many could not afford food. Those who already had 3 or more guns went out to buy more to shoot the little virus. Politicians blamed everyone but themselves. But imagine, and then came a vaccine. People no longer stayed inside. People no longer wore masks or socially distanced. People were much nicer to one another. People used electric cars and flew less to keep pollution away. People were excited to go to football games. But then they went back to being as they were before, self-centered, not caring about others, and the world was sad again. And I'm going to show you here my hamster. Hopefully you can see, oh, I'm looking, I've got to get this on the camera. You can see the hamster is wearing a mask. This is because the best study to show that masks worked was where they put hamsters in 2 cages next to one another, and they put a mask between the cages. And the majority of the hamsters in the cage next door who were masked off did not get basically COVID. Masks are the secret of getting rid of COVID, and no one should basically say that's not the case until we have much better data to say. So I leave you here with this young lady who got the 1918 Spanish flu pandemic and then got COVID, and she was has lived to 107. And you see a lady from Spain who got COVID and lived through it, and she was 113 at the time she got the COVID. So we have to recognize the storm will pass, the sun will shine again, vaccines will come. So as the sun shines again, we need the vaccine, we need masks, and hopefully you all will go out there and work hard on primary and secondary prevention, which is the mask wearing, so until we get the vaccine. Thank you all very much. I'm really lucky I can How does this not going to work? Okay, so I can't see for some reason whether they're questions. I realize we're late and many people are leaving. But did anybody send questions, or can they
Not
ask?
that I have not seen any questions. I see lots of thank yous for the lecture.
Okay, well, as long as everybody doesn't have questions, that will be fine, because I have a Zoom meeting at 1 o'clock. So basically, we've met it. Sorry I went on so long, but I tend to get carried away about the excitement of getting some sort of message through. And all of you, it's whether you're a DO student, just a normal person out there on the street, it doesn't matter. You can make a huge difference by educating people. You are the future, because we cannot continue to believe that not wearing masks is a useful thing. It's not a political thing not to wear a mask. And let me tell you, when I was young, I would have not wanted to wear a mask either. So good luck to you all. And it's wonderful always to talking to the people from Kirksville. You're doing a wonderful job. And every time we've got a resident who's come down from Kirksville, or a student from Kirksville who's done geriatrics, they have been outstanding geriatricians. So I hope you all decide you want to be geriatricians. And with that, I'll stop. Thank you all very much.
Thank you, Dr. Morley. Christina Grant did comment that you haven't tweeted lately. She looks forward to them.
Good. Well, I actually tweet a lot every day. So I should point out for the students, I tweet under @MedDocSlu, MEDDOCSLU, where I try to put out each day a single medical factoid that's useful. That's the easiest way to learn enough medicine to pass the stupid boards that you could write. Okay, thank you all very much.
Thank you, Dr. Morley. We appreciate it.